Welcome and thank you for joining us for tonight's BCNA's webcast on living well with metastatic breast cancer. I'm Vicky Durston, Director of Policy and Advocacy with BCNA, and we're lucky enough to be joined by Dr. Michelle White, Medical Oncologist, Gillian Cross, Metastatic Breast Cancer Nurse Practitioner, and one of our consumers with metastatic breast cancer, Katrina. Katrina joins us remotely from home and we welcome her, but we also here welcome our team, and we're so privileged to be able to have them here with us tonight. I think BCNA is committed to ensuring that we address those issues and challenges faced by people affected by metastatic breast cancer. Tonight we will have the opportunity for you to ask questions that we will get to after each presentation, and obviously these sessions are always difficult to keep to time, but we'll do our very best and navigate our way through together. So thank you and welcome. I think we're just going to kick off firstly with BCNA addressing the issues, and you can see there up on the slide our commitment to ensuring that we have continued updated information that is current and relevant. Our My Journey online tool at BCNA and the revision of our Hope and Hurdles information guide, together with our webcast and podcast series, is our commitment in partnership with Cancer Australia to be able to deliver the very best information and support to those affected by metastatic breast cancer. We continue to advocate for metastatic breast cancer nurses funded by the McGrath Foundation, and obviously the training needs that support that you'll hear from Gail a little bit later, and also advocating for innovative tests, new drugs and therapies. We continue to raise community awareness and obviously the financial impact around breast cancer. So I won't go into too much detail because we want to throw straight to our experts, but did want to reference Cancer Australia, and certainly if you go to their website you can see the work that BCNA has done to develop these 10 key appropriate principles that really help navigate treatment and care through a diagnosis of metastatic breast cancer. A number of our consumers were involved in this pivotal project, and certainly if you go to the website you can see the work that's been done there. So without any more delay, I'm going to hand over to Dr. Michelle White, one of our medical oncologists here tonight. Thank you.
Many thanks to Vicky and the team from BCNA for inviting me to be involved in tonight's webinar. I'm going to set the medical scene for tonight's discussion of living well with metastatic breast cancer. So first, what is metastatic breast cancer, otherwise known as stage 4 breast cancer or advanced breast cancer? Essentially, this describes when breast cancer has spread beyond the breast and the local lymph nodes that are found in the armpit and above the collarbone. Breast cancer commonly spreads to a number of organs that are shown in my diagram. So you can see that the common sites of spread are lungs, liver, distant lymph nodes, and bone disease. The most common way that a woman will present with stage 4 breast cancer is after having had early breast cancer in the past, developing new symptoms, and having investigations which unfortunately demonstrate spread to one of these sites. Much less commonly, a woman can actually present when she's diagnosed with breast cancer with spread that's already taken place to other parts of the body. While generally not considered to be a curable illness, for many women who are diagnosed with stage 4 breast cancer, it's often a controllable illness, often for significant periods of time. And one of the most important things I say to my patients when they're diagnosed with stage 4 breast cancer is that there are many treatment options available to that woman. I think that's a really comforting piece of news for a woman who's diagnosed with stage 4 disease. It is really important with stage 4 disease to ensure we identify which subtype of breast cancer a patient has, which is usually the same as her original disease, because this provides us with the most important information about effective treatment options and also what her prognosis might be. The most common subtype of metastatic breast cancer is hormone receptor positive or estrogen receptor positive breast cancer, and over 70% of women diagnosed with metastatic breast cancer will have this subtype. The next most common, affecting less than 20% of women, is what we call HER2 positive, or women who have HER2 amplified breast cancer. And the least common subtype is triple negative breast cancer. That means the cancer is not driven by it doesn't have estrogen receptors or HER2 receptors, so is known as triple negative disease. As I mentioned before, there are many treatment options for women who are diagnosed with metastatic breast cancer. And this is definitely not a complete list of the treatment options, but I really just wanted to present some of the commonly used treatment groups that we use for metastatic breast cancer. As I mentioned, the most common subtype is hormone-positive breast cancer. And for this group of women, endocrine therapies can be a very important component of their treatment. Oncologists like these treatments for two reasons. One, they're very active drugs. And secondly, they're generally really well tolerated and allow a woman to have a really good quality of life while on these medications. Recently, a new class of drugs called the CDK4/6 inhibitors, which I'm going to discuss a bit more in a minute, have been identified, and these make some of these endocrine therapies even more effective. For most women diagnosed with metastatic breast cancer, chemotherapy will be one of their treatment options somewhere during their illness. Again, there's a long list of drugs that have activity for stage 4 breast cancer that are chemotherapy drugs, and they vary in their effectiveness and also in their side effect profile. And I've just highlighted a couple of the points that are important about chemotherapy. Obviously, some of them cause hair loss, some don't, and this may factor in decision making, and some of them can be oral medications. However, unfortunately, at this point in time, the majority remain intravenous treatments. And the final group of treatments are what we call targeted treatment. Now, in many ways, endocrine therapy is also a targeted treatment because it does target the estrogen receptor. But more and more treatments are trying to identify a specific characteristic of the cancer and really target down on that, such as the 3 drugs mentioned there that are all useful treatments for HER2 positive disease. Patients with stage 4 breast cancer will generally be on some form of treatment for the rest of their life. And the usual pattern is that a treatment will be effective for some period of time, and then unfortunately the cancer will develop what we call resistance to this treatment, and either the current lesions will grow in size, so the areas affected will grow in size, or new sites of disease will be found. Unfortunately, for some patients, we start a new treatment and it's not effective from the time we start the treatment. And obviously this is a devastating situation for the patient. We usually use some sort of scanning to identify how the treatment is working. And I've just put up on my slide tonight 2 pictures which are PET scans of a patient. The image on the left is of a woman newly diagnosed with metastatic breast cancer, and the black areas represent active sites of cancer. And you can see after a few months of treatment, the image on the right shows less dark areas, and also many of the dark areas are not quite as bright as they were initially, suggesting a really good response to treatment. Whenever we have a point where the treatment is no longer being effective, it's really important for the oncologist and the patient to sit down and review their options. Now, as oncologists, we typically like to use the most effective treatments early in a patient's diagnosis, often because they're most active when they're used earlier in the patient's history. However, sometimes the patient might decide to have a less active treatment that has a more attractive side effect profile for their particular point in life at that stage. And you can see that the patient really has a major role to play when deciding on the next line of treatment. And this is in comparison to Mad Men, where Betty is sitting in the doctor's room. And sorry, the doctor's a little bit cut out, but maybe he should be a bit cut out because he's explaining to the husband that the patient has cancer without even involving the patient in the discussion, a very old-fashioned paternalistic model of oncology. There are many new drugs coming through in the setting of metastatic breast cancer, and certainly an example of this are what I mentioned before, the CDK4/6 inhibitors. And there are 3 drugs in this class, Ibrance, Kisqali and Venetio, and these drugs are all available through the PBS, And what they essentially do is they make endocrine therapy or the hormonal therapies even more active, and often it's a longer time before a patient needs to move to another line of treatment. These drugs are all now available through the PBS as first-line treatment for women with hormone-positive breast cancer, and BCNA played a very critical role in advocating for patients with advanced breast cancer to get these drugs available through the PBS, and certainly all oncologists are very grateful for their role in this setting. Another exciting new treatment is immunotherapy, which has really changed the landscape for some cancers, such as melanoma and lung cancer. And often many patients with advanced breast cancer are really interested to know whether immunotherapy might be a treatment option for them. We do now have a clinical trial that has demonstrated a significant benefit for women with triple-negative breast cancer using a combination of immunotherapy with chemotherapy. This combination is not yet on the PBS, but hopefully will be soon in this setting. Unfortunately, there's often a long lag period between the time when we can demonstrate a drug is a good drug and the time that it's available through the PBS. And this is often really frustrating for women who are reading about these new agents and frustrated they can't access these drugs. Sometimes pharmaceutical companies will set up what's called an access scheme where patients can access the drug prior to it getting its PBS listing. Often in this setting, there is a cost implication for the patient. So often they have what they call a cost share arrangement where the drug company may provide some of the funding and the patient is asked to also provide some of the funding. And it's important for a patient to discuss these sort of access schemes with their oncologist to let them know where they stand in regards to this. For many patients, however, these financial costs are excessive and beyond their reach. And I try to reassure my patients that often an access scheme does mean a drug is getting close to getting its PBS listing. So hopefully they won't be able to, it may not be far away before they can access the drugs, or consider being in a clinical trial where this drug is being further investigated. Because stage 4 breast cancer is an incurable illness, there is an enormous amount of research trying to identify new effective treatments. And there's a very standard process of clinical trials that have to take place before a drug is accepted to be what we consider to be the new standard of care for women with stage 4 breast cancer. And I think all patients hopefully do discuss with their treating oncologists the option of participating in clinical trials. I would like to point out that clinical trials are not for everyone. And that's important to be aware of the sort of person you are and whether that's a treatment that would sit well with you. And I have put together just a little table of what I consider to be the pros and cons of participating in clinical trials. Clearly, the main advantage is going to be that you may well get access to new effective treatments. But there are other advantages, such as the fact that patients are very closely monitored on clinical trials. Obviously, there's no out-of-pocket costs associated with the clinical trial. And of course, a patient can withdraw their consent at any time. The disadvantages are that a patient doesn't have a choice about their treatment. And going back to that discussion that patients often have with their doctor, that sort of interaction certainly has to be removed in a clinical trial. They may not get the drug they were hoping to get on a clinical trial. And certainly trials are very labour intensive for patients. And certainly many trials are what is known as blinded. So that often means the patient and often the doctor are unaware of whether the patient is actually getting the treatment that they were hoping for. I just wanted to finish up on what I believe will be the way forward in oncology, and that's personalised oncology. I mentioned earlier that we have these standard treatments for the particular subtypes of breast cancer, but they don't always work, which clearly is due to the fact that cancer is far more complex than our current understanding of it. And clearly one size does not fit all patients. Recently there's been the development of tests that are known as molecular profiling tests that are really trying to identify what genetic changes are driving a cancer's growth. And the aim of doing this would be to try and identify targets that we might use for treatments to attack that cancer. These tests are currently not standard of care and they can be accessed, but again, unfortunately, they're very expensive. Some patients may want to discuss this cost with their oncologist. Certainly, as I said, these tests are not standard of care, and it's an important thing to discuss with your doctor. However, some clinical trials will also offer some sort of genetic testing or molecular profiling when you participate in a clinical trial, and that's another additional benefit of participating in a clinical trial. So in conclusion, metastatic breast cancer is a devastating diagnosis, but it's an illness with many treatment options. New treatments, especially those targeting specific subtypes of breast cancer, are being developed, and patients do have a strong voice in deciding the right treatment for them at each treatment decision-making point. And clinical trials are important and may well offer patients the opportunity to access new effective therapies. Now I'll pass on to Gil.
Thank you, Michelle, and thank you, Vicky and BCNA for inviting Michelle, myself and Katrina to come and talk to you tonight. And I'm very excited to be talking about this topic, living well with metastatic breast cancer. And I'm going to focus on the nurse's role in providing optimal supportive care. So I'm a metastatic breast cancer nurse practitioner, one of 4 practicing and endorsed breast cancer nurse practitioners in Australia. And that just means that we've done a master's in nurse practitioner and have that extra scope of practice to be able to do things like prescribe certain medications or order diagnostic tests. And I work with a couple of very knowledgeable metastatic breast cancer nurses at Monash Health at Moorabbin Hospital, who we all work as a team with Michelle and the other oncologists to provide the optimal supportive care to our patients. One of the very talented metastatic breast cancer nurses that I do work with, she is funded by the fabulous McGrath Foundation. And like I said, our job is to provide supportive care to those with metastatic breast cancer. So what is supportive care? It's the services, information and resources that may be required to live as well as possible. And I can't emphasise that enough, to live as well as possible after a diagnosis of cancer. It complements cancer treatment and is an important part of comprehensive cancer care. And there are 5 interrelated domains of supportive care. There's the physical domain, and that can relate to physical symptoms of metastatic breast cancer, or it could relate to side effects of treatment. There's the social domain, and that relates to a cancer's diagnosis on someone's ability to be able to work, to be able to socialise. It can relate to finances. And then, of course, having a diagnosis of metastatic breast cancer can have a great impact on a psychological impact on people. They're faced with uncertainty, and that can create a lot of anxiety. Then there's the spiritual domain, and that relates to a person's belief about themselves, their purpose in life, or existential concerns. And then information. Information relates to all those other 4 domains, and it's so important that you get the right information at the right time. And that could be information about your breast cancer or information about the treatment and supportive care options available to you, about the resources that could help any concerns in any of these domains, and any practical tips. And if I may use an example on how these domains are interrelated, Michelle might prescribe intravenous chemotherapy such as Abraxane to someone, and we've just heard that many of these intravenous chemotherapies can cause side effects such as alopecia, a loss of hair, and that can impact enormously on someone's identity, their purpose in life. It can impact on their confidence, their body image, and whether they feel comfortable with going about day-to-day activities like going to work. and information on certain things like what cancer centres provide. Scalp cooling might be very important to people, or they might need some information on where to get wigs. Or there's a great service called Look Good, Feel Better that provides practical tips on how to effectively apply scarves, how to effectively apply makeup and improve someone's body image so that they can go about their daily interactions. So information is a very important domain of supportive care. So let's talk a little bit more about supportive care in the metastatic breast cancer setting. Having metastatic breast cancer can mean that you have high levels of unique and complex supportive care needs. And people say that these supportive care needs differ greatly from when they were first diagnosed with breast cancer. And having a diagnosis of metastatic breast cancer can be considered so much more distressing. But we know that metastatic breast cancer patients are living longer and that treatments are improving survival. So the supportive care needs of people may vary over time and can be person dependent. We know that many people experience heightened distress at diagnosis of metastatic breast cancer, when disease progresses or when treatment change is required. And many report common concerns about living with a sense of uncertainty and loss of control. They worry about those close to them. They want to know how to maintain a good quality of life and how to live well with metastatic breast cancer. They want to know their treatment and supportive care options. And back in 2013 and even earlier, we started identifying that there were many gaps in supportive care for those with metastatic breast cancer. And we realised that there was a need for specialised nursing skills and knowledge. So back in 2013, I worked on a project with the Southern Melbourne Integrated Cancer Services on developing a model of care for a specialised metastatic breast cancer nursing role. And we've since been promoting this role at cancer conferences, and the McGrath Foundation and Breast Cancer Network Australia have been very supportive of developing these new roles, and they were instrumental in lobbying to the government. And in January 2019, the federal government pledged funding for 30 or more metastatic breast cancer nurses over the next 4 years. So what is the role of a metastatic breast cancer nurse? They can be your contact person so that you can report any concerns. And we encourage you to report small concerns so that we can help you before they turn into big concerns that are harder to manage. And because people are living longer with metastatic breast cancer, we're able to build a rapport with patients and their families and provide information and support and continuity of care along the way. We provide information on treatments and supportive care options. We monitor and manage symptoms and side effects of treatments, which help prevent inpatient or emergency department admissions. And we can facilitate direct to the wards admissions, which is a much better experience than having to go through emergency. We participate in multidisciplinary care. At Monash Health, we have a weekly metastatic breast cancer multidisciplinary care team meeting, where the oncologists and the other specialised doctors like radiation oncologists, palliative care specialists, allied health, and the metastatic breast cancer nurses, we all talk about new cases of metastatic breast cancer, or talk about each time a patient may have their disease progression, and we get our heads together and we come up with recommended treatment options that we can give each patient. We help coordinate care. We communicate and collaborate with your healthcare team. We do referrals to the community and hospital-based services and link people into resources. We monitor those on oral anti-cancer therapies, and Michelle has mentioned some of those, like the CDK4/6 inhibitors like ribociclib, palbociclib, abemaciclib. There's capecitabine, an oral chemotherapy, and there's everolimus. And we want people to be able to tolerate these treatments, so we closely monitor them and help with any side effects so that they are more likely to stay on these treatments and have better outcomes. We administer many injectables such as Faslodex, Zoladex, denosumab that are given in the metastatic setting, and we provide lots of counselling and listen to our patients when they need to talk. And we facilitate some of those difficult discussions on goals of care. And we know that the goals of care in the metastatic setting are to try to prolong life and preserve quality of life. And we encourage people to talk about advanced care planning, and we may need to refer people into palliative care. And these are often taboo subjects that people feel uncomfortable about talking about. But I encourage people to be able to do so, because that is taking control of the future and making decisions when a time when you feel like that you're out of control. And palliative care services, people are uncomfortable with that term often, but because they worry that it means that they might be approaching end of life. But we're not recommending people to be referred into palliative care just for end of life. We also refer to help symptom management and keep people in their homes as independent and being as independent for as long as possible. And did I mention supportive care? Of course, that's what we do. We provide supportive care, and we conduct supportive care screening and assess and address any supportive care concerns at those key times of distress. And this is a supportive care screening tool that we often get our patients to complete at Monash Health at those key times of distress. And that helps us measure their levels of distress and identify any concerns or areas that they might need practical help, so that we can then do the necessary referrals or link people into the necessary resources to help them. And there's a similar supportive care tool that you can actually find on the We Can website, and print that out and complete it and take it to your nurse or doctor and can talk through any supportive care issues. This website is a really good supportive care website to find all the different cancer services that exist, and I encourage you to look this up. And on this website, of course, is Breast Cancer Network Australia. And I really encourage you, when you're looking for your information, to go to credible resources, because there's so many resources on the web, but they're not always credible. And Breast Cancer Network Australia is on the top of my list, and they've got the My Journey online tool that I hope that you've all registered for. And the McGrath nurses give this postcard out to many of their patients when they're first diagnosed with metastatic breast cancer. And although it has a counterpart in Think Pink that are very Victoria-centric, they also are relevant. And I encourage you to look at what resources, similar resources that you might have in your state. The Cancer Council and McGrath Foundation. They're all credible sources of information. They all provide credible sources of information, as does Cancer Australia, National Breast Cancer Foundation. And then there's the programs like the Look Good, Feel Better program or the Living with Cancer program that provide practical tips. And then there's the Otis Foundation that provides different holiday houses where you might want to go and stay with your family. There's Gather My Crew. This is a great platform. All friends and family, they want to help, and you can register for Gather My Crew, and that can direct your friends and family on areas that you might need help in. And always look at your local hospital and what community health services, what resources they have. There's lots of allied health like psychology, counsellors, dietitians, dentists, social workers, exercise physiologists, physiotherapists, occupational therapists. And you can go to your GP and get a mental health plan or a chronic illness plan to get subsidised visits to many of these services. At Monash Health, we have specialist clinics like a menopausal clinic, lymphedema clinic, familial cancer clinic, sexual health clinic that we refer our patients into. So explore what sort of services like this that your local hospital may provide. And of course, specialist nurses. You can always go to your breast care nurse, palliative care nurse, district nurse, oncology nurse, or radiotherapy nurse. They're all willing to help you with information and support. And again, if you're not sure who your breast care nurse is in your local area, I encourage you to look up the McGrath Foundation website to find out who that is. And of course, I've already spoken about the specialised metastatic breast cancer nursing roles that are now starting to emerge. And in recognition of these new roles, we are working on a collaborative program at the moment that involves Breast Cancer Network Australia, MICS, Southern Melbourne Integrated Cancer Services, Monash University, McGrath and Monash Health. We're all working collaboratively together to design, develop and evaluate a national practical tailored metastatic breast cancer nurse training program, where nurses around Australia can come to Monash Health and get some practical experience with looking after those with metastatic breast cancer. And on the McGrath Foundation website, we're going to offer an online learning modules in these core and elective modules. And the aim of this training program is to train nurses in providing best supportive care to those with metastatic breast cancer to help you stay as well as possible for as long as possible whilst living with metastatic breast cancer. So in summary, I really encourage you all, if you haven't done it already, to register for the My Journey online tool, to access those credible resources that I've spoken about in a previous slide for information and practical advice. Contact your local breast care nurse, and BCNA and McGrath also have information on who that may be. And also BCNA has a hotline that you can ring. So I really encourage you to reach out and find out what resources you can access, find out who your breast care nurse is, and get that supportive care so that you can live well with metastatic breast cancer.
Thanks, Gil. Thank you, Gil, and thanks for that presentation. Before we go to Katrina, and I am mindful of the time, we did have a question, Michelle McKenna. Thank you, Michelle, for putting your question to us. And I'm going to pose the question to Dr. Michelle White. Certainly, why are new drugs on the PBS perceived as only for first line of treatments and not for those of us who have already been through many lines of treatment? Could you expand on that a little bit for us?
Sure, absolutely. Thanks, Michelle, for the question, and I think it's a really important one. When governments put a drug on, when the Australian government put a drug on the PBS, they really only provide it for the indication as it was in the clinical trial. That's usually a very big clinical trial that showed the benefit of that medication. So patients will have to have the same characteristics of as the patients who went on the trial. I mentioned earlier that often drugs have their most activity when they're used early on in a patient's illness. And so often treatments are initially in a first-line setting. Not always, and sometimes drugs will be offered in a second or third-line setting, but you're right, often it is in a first-line setting. And I share your frustration for many patients who were diagnosed before that time and that then don't have the ability to access these drugs. It can be incredibly devastating and frustrating. I think it is important to know that sometimes these drugs are less active if you've had a number of other lines of treatment, and so it may not even be in your best interest to have that medication. But again, that's something to discuss with your treating doctor. Again, sometimes there are access schemes for later line patients to get these sort of treatments. But again, sometimes there's a financial cost, which is really something that, you know, if I had my way, there would be no costs associated with patients accessing these drugs. But I understand it can be incredibly devastating and frustrating for the patient.
Thanks, Michelle. Katrina, welcome and thank you for joining us.
Thank you very much, Vicky. I appreciate it.
It's great to have you here with us. I suppose I've got a couple of questions for you. So just when you were first diagnosed with early breast cancer, if you can just explain to us what kind of treatments you had and what were some of the things that helped and hindered you through that process?
Okay, well, I was diagnosed in 2011 with early breast cancer and then immediately went into surgery, chemotherapy and then radiotherapy after that. It was quite an immediate thing and kind of like a bolt from the blue as well. But things had to sort of happen really quickly to kind of effectively treat the cancer at that stage. It was very strange at the beginning because it was hard to know what would be helpful and what would not. because you're in such a state of shock and it's all so new. And I was completely trusting of the doctors. I have no medical knowledge myself. So I was definitely in the hands of my doctors and the medical teams. And so it was really just navigating this early journey of how to get through this as best as I could. And I just think it was extremely overwhelming. And that was quite difficult to sort of navigate, I think. And for me, the thing that was sort of helpful was to just basically get through it as best as I could and get a sense of normality back into my life. That was the one helpful thing that I kind of drew on all the time, was to keep my life as normal as possible where I could, going through something as traumatic as this. Yeah.
And can you expand for us, when you had your second diagnosis that was then classified as metastatic breast cancer,
yes.
What treatments you're on, and if you're on treatments now? Can you expand on that a little bit for us? Yeah.
Yeah, sure. So then I was diagnosed again in 2016 with advanced breast cancer, and it was so wonderful hearing Michelle and Gil talk about it, because yes, it is really devastating, and it's a very different diagnosis to the first one. The first one is essentially you can approach it quite positively. The advanced breast cancer is quite terrifying and devastating, and I didn't know very much about it. So it was very, very helpful to have conversations with the medical team that were positive, and I didn't realise the amount of treatments that were involved and were available to me. So that was a revelation, and is also something very positive for a patient that's going through something like that. I feel like I've been through quite a few. I went on a trial, which was I was actually really encouraged to do that, and unfortunately it didn't. The cancer travelled within the trial, so I had to get off that particular trial. And then I went on a couple of hormonal therapies. And then I went on to an oral chemotherapy, and I'm now currently going through intravenous chemotherapy. So I've been through quite a few stages, but over several years. So, it is. It's every year is a gift, but it's also fantastic that each of these treatments prolong your life in a very good way as well. I've been quite surprised at how well I've lived, at how well I can live on these particular treatments, even though there are different side effects and stuff like that. It's been a lot more. I've been able to cope a lot better than I thought. Yeah.
Yeah, and Katrina and I were talking today, and Katrina, can you explain how do you find balance and how do you create balance in your life?
Look, I tend to not concentrate so much on my illness all the time. I'm sure all patients are the same, and fill my life with other things. Definitely physical therapy has helped tremendously for me. Positive reinforcement, trying not to dwell on things, and definitely surrounding yourself by a supportive medical team. Gil is wonderful, and having that support as an advanced breast cancer nurse has been really, really helpful for me, because I've always had somebody to go to if I've had a question, big or small. Never felt like I couldn't ask anything of her, and she immediately replied. And with Michelle, always a very positive approach, proactive, concentrating on things that are actually going to help you move forward in a very positive light, and so that you can continue to live very productively and have a very full life, and just try and manage your illness and give it the time that it requires, but also give your life a chance to sort of flourish outside of your illness, I think.
Yeah. And can you talk us through, were there changes that you needed to make in your life in relation to your career that you could share with others around how that impacted you?
Yes, well, I was, with my first diagnosis, I was a full-on career girl, very hardworking, long hours, very high at the top of my game. So it was very difficult when I got that first diagnosis, and immediately just wanted to fix the cancer and get back to my career. And I did that until my second diagnosis, and then I realised that I had to make a change so that I could accommodate dealing with the illness in the best way that I could, as well as making my life productive. So unfortunately, I've had to not do the job that I was trained to do and that I love, but still work in my industry, but work part-time. So it was completely devastating for me not to have the career trajectory that I thought I was going to have. But I'm grateful that the treatments have given me the possibility to still work and be a part of my industry. But it has been very difficult. It still is quite difficult not to do the job that I love doing. But I'm making the most of it. Yeah.
Yeah. And if there is one thing that you could share with our audience tonight that would be helpful, or a takeaway message that you think could be useful, is there something that you could share with our audience?
We were talking about this earlier. I think for me, the cold cap has made, because I'm going through intravenous chemotherapy at the moment, I'm using the cold cap, and my hair is not amazing. I haven't washed it for 4 months. It's disgusting, but it has made 100% difference to me to be able to wake up in the morning and look at myself in the mirror and actually feel like myself, and to still maintain my identity as a person. It's ridiculous, but losing your hair is one of the most devastating effects of going through chemotherapy. And even though you're going through a life-threatening illness, the fact that you lose your hair takes away all of your anonymity and the ability to be a person who's not judged. And I think it's just one of those things that is immediately recognisable as a cancer patient. And so it's been wonderful to have the cold cap, and I can't recommend it enough. It's been a gift, a real gift for me. So that's been fantastic.
Thanks so much, Katrina, for sharing your story with us tonight. We really appreciate it. I do have a question for Michelle. We've got a question here from Chantel asking around, as a medical oncologist, your thoughts around alternative drugs or treatment supplements, some things that might be prescribed for heart disease, but other things that might interact with treatments. So what's your thought and take on this?
So, again, when we come back to an illness that our standard treatments can't cure, it's completely understandable that patients will look at other alternatives that might either work in conjunction with their treatments or as an alternative to standard treatments. And each oncologist will have a different opinion regarding this, and it's certainly so important that the patient has the honesty and trust that they can talk to their treating oncologist regarding this. I'm generally probably at the more flexible end of the spectrum from that perspective. If a patient wants to explore other treatments, as long as they're upfront with me about what they're doing, and certainly as long as I'm sure there's no interaction with any of their standard treatments, I don't have a problem with them exploring other options. But certainly there often is not a great body of evidence about effectiveness of other treatments. Now, I know many patients will say to me, but that's because all clinical trials are run by big pharmaceutical companies. And certainly we do acknowledge, that their clinical trials are very, very expensive things to do. But we do try to be evidence-based in oncology. Mm-hmm. And so we do try our treatments to be ones that we know are effective.
Yep. Thank you. I do have another question from Katie Thorpe, and thank you, Katie, for sending through your question. Katie's a newly diagnosed 28-year-old with metastatic breast cancer. How does she go about seeking out understanding what clinical trials are available? Should this be consulted or recommended by her oncology team? And where are the best places to learn about new clinical trial opportunities?
Yeah, so is it within Victoria or?
We haven't got in Victoria there.
Certainly the Cancer Council have a really good list of clinical trials that are available, and there are groups like Cancer Trials Australia that coordinate lots of clinical trials. But certainly the first place to start would be with your treating oncologist. In the past, doctors tended to be very protective of their patients and not really want their patients to go to other hospitals to participate in clinical trials. Now we're so excited about the breadth of treatments that are out there in clinical trials. I think we're very collaborative. You know, I would have patients go on clinical trials on the other side of town and then return to my care when that treatment's no longer effective. So I certainly think the first place to start would be with your treating oncologist. Or breast care nurses at your hospital will also have resources, but certainly the Cancer Council will certainly have good information as well.
Great. I am mindful of the time, and we could sit here all night. I know these two personally, they inspire me, and Michelle and Gil are experts in their field, and I just want to thank them both for being here tonight. They both do an extraordinary job, and certainly thank you to Katrina for joining us tonight from home. We appreciate your courage and wish you all the very best in your treatment and care. Just to let people know that our resources, please visit our My Journey online tool, and you can sign up. It has the latest treatment and certainly COVID-19 information related to the impact to metastatic breast cancer, and all links to the department and Cancer Australia frequently asked questions, also our website, and you can also speak to our helpline where we have cancer nurses on 1800 500 258. I'd also like to acknowledge the team at BCNA that helped put together this webcast. Ricky, Kate and Laura, fantastic team to work with, and also Cancer Australia for their incredible commitment to the support of metastatic breast cancer. So thank you for joining us and good evening.